Hello everybody and welcome to today's seminar. My name is Nicky Whiffin. I'm a group leader and Sir Henry Dale Fellow at the Wellcome Centre for Human Genetics in Oxford, and I have the huge pleasure of introducing today's speakers. Before I do that, I'm just going to quickly introduce the Centre for Personalised Medicine for those of you who might not be familiar with us. The CPM is a joint initiative between the Wellcome Centre for Human Genetics and St Anne's College in Oxford. We organise seminars and also larger events around all aspects of personalised medicine. To hear about our upcoming events, please give us a follow on Twitter. And for recordings of our past events, including recent talks by both Jennifer Doudna and Adam Rutherford, and links to both our blog and our podcast series, then please head over to our website, which is cpm.well.ox.ac.uk. So turning to today's event, we are hugely privileged to have two amazing speakers with us today. Cristen is an associate professor at the University of Michigan, where her group analyzes large-scale genetic data sets to understand the biological basis of cardiovascular and metabolic diseases. Cristen did her PhD in Oxford before she moved out to the US, and she's led multiple studies that have collectively identified hundreds of genetic loci that influence the risk of cardiometabolic traits. Joining her in conversation today is Rajani Aatre, a genetic counsellor in the Cardiovascular Centre, also at the University of Michigan. And I'm super excited to hand over to both Cristen and Rajani to tell us about their experience returning actionable genetic variants to biobank participants. This is a super important topic, particularly as the size of the population genetic data sets that we sequence is growing. But it's also a great example of the power and importance of collaboration between both academic scientists and also medical professionals. So now I'm going to hand it over, so please take it away.
Thank you, Nikki. So I'm just going to share slides. We have a little under 30 slides, so we thought we'd try and use about half the time to walk you through what we've done at the University of Michigan to return research level results to participants. And then we'll have lots of time for questions and dialogue, and I think the questions can go into the Q&A section. So I'm going to speak about the first part and then hand it over to Rajani, and then we'll both be available for any questions at the end. So yes, what we're talking about today is what we've learned about returning research genetic results to patients in aortic clinic. And this all happened at the University of Michigan. So disclosure slide. So let me reduce my thumbnail there. So the work that we're talking about today is born out of a biobank called the Cardiovascular Health Improvement Project. So this is where we recruited patients to join research studies from the University of Michigan Frankel Cardiovascular Center. And we collected DNA as well as health information, some survey data, and generated genetic data. The biobank has about 5,000 participants at this time. We focus on collecting patients with a clinical diagnosis, primarily of aortic disease, so thoracic and abdominal aortic aneurysm and dissection, bicuspid aortic valve, heart failure, arrhythmia, and dyslipidemia, but the vast majority of biobank participants are related to aortic aneurysm. And as I mentioned, we collected phenotypic information from the EHR, family history information, DNA, plasma, serum, and aortic tissue samples when available. So thoracic aortic dissection is fairly rare, about 3 to 4 per 100,000 people per year. However, it's highly heritable. 38% of thoracic dissection cases, at least in our biorepository, have an affected first-degree relative. Sorry, I'm getting a little echo, Rajani. Maybe if you want to just mute for a minute. Risk factors for aortic dissection include smoking, hypertension, hyperlipidemia, and atherosclerosis. And so we really wanted to look into the clinical implications of identifying genetic variants, especially pathogenic variants in aortic dissection patients by using whole exome sequencing. Just a quick mention that although aortic dissections and aneurysms are rare, they are extremely serious. So the first two individuals here, John Ritter and Lucille Ball, I believe, died from a thoracic aortic aneurysm, and I think thoracic aortic dissection, sadly. And Albert Einstein died from, I believe, an abdominal aortic dissection. So back to our exome sequencing study, we selected every available patient in our biorepository who had had an aortic dissection, which is a tear in the wall of the aorta. And we identified 249 patients whose dissection was caused by something other than trauma. So if someone had a car accident and came in with an aortic dissection, they were excluded from this study. And then we selected age, sex, and ancestry match controls for each patient. Unfortunately, we discovered that the trauma-induced dissections were included in our initial analysis, and then we debated how to handle the extra controls from those matches, and we opted just to leave everything in, so we didn't appear to be data mining by after the fact deciding which controls to include. So the University of Washington happily performed exome sequencing for us. This is Debbie Nickerson's lab, and they're top notch at doing exome sequencing. And then our initial goal was to identify novel genes. So we performed association testing with a particular focus on obviously the coding variants, and we performed gene-based burden testing to see if any genes had a collection of pathogenic variants that might cause dissection. And unfortunately, I'm not sure why I'm going backwards, but there were no genome-wide significant results or single variant results or anything significant by a burden test. So we were a little sad, but it is what it is. The data is what the data is, or are, depending on your preference. But we next wanted to ask whether we could annotate specific genetic changes within the known genes that cause aortic dissection. So we used the guidelines from the American College of Medical Genetics, and we used specific rules related to do healthy controls carry the genetic change? Has this genetic change been studied in mice or other model systems? Does the genetic change track with disease in specific families? And we also used computational predictions of the impact of a specific genetic change on the protein. And then we annotated the variants within the 5 categories with a particular focus on pathogenic and likely pathogenic. So again, we're just focusing on the 11 known genes that cause aortic dissection. And we outsourced the decision of whether a variant was pathogenic or not by sending a list of variants discovered in either our cases or the controls to Diana Milowitz, who is an expert physician and geneticist in the area of aortic aneurysm and dissection at the University of Texas Southwestern. And her team performed the ACMG calling of whether variants were pathogenic or not, completely blind to whether the variant was observed in a patient or a control. And just to keep in mind, the rate of VUSs is something like on the order of 20 to 30%. So 20 to 30% of the population has a VUS in at least one of these 11 genes. So that we sent them a long list of variants and sort of asked them to pick the needle out of the haystack in terms of pathogenic variants. So I basically just described the study design. Within those 11 genes, we had a list of variants that were annotated as pathogenic from this external lab in Texas. And what we identified were 25 unique pathogenic variants in 26 individuals. When we unblinded in our lab after we received the pathogenic calls, what we found is that every one of the pathogenic variants was observed in a case and 0 were observed in controls. And that made us feel more confident about the assignment of pathogenic variant status. So we observed in unrelated cases, 25 pathogenic variants, and one of them was a first degree relative of one of the 25. So 26 pathogenic variants. And that helped us either provide new clinical diagnoses or refine the diagnosis for 9 individuals. One patient had a revised diagnosis from Marfan to Lilly's-Dietz. There were 4 new diagnoses for Marfan syndrome, 1 new diagnosis for vascular Ehlers-Danlos, and 3 new diagnoses for familial thoracic aortic disease due to mutations observed in the LOX gene, PRKG1, and SMAD3. So the conundrum after this exome sequencing study was that when we summarized the findings to the CHIP steering committee, which mainly consists of cardiologists, thoracic surgeons, and cardiac surgeons who treat these same patients, the physicians said their care of the patient and the patient's family members would change based on this genetic information. And they felt it was critically important and potentially even life-saving to get these results into their medical record so appropriate clinical action could be taken. So we next asked around, does the University of Michigan have a protocol? Now keep in mind, this is around 2014, 2015. Does Michigan have a protocol to return research level genetic results to study participants? Until our study, research results were never returned to patients because they are not clinical grade. And the IRB specifically asked us, do the participants want this information? Would participants endure any harm or stress from this result? What are the risks of returning results? And would participants have any impact financially, such as insurance costs? Because we specifically stated in our consent to the research study that the study would cost them no money. So the IRB was quite hesitant to consider returning research level results, that it was clear that clinical decisions cannot be made using research grade results. And we also needed to respect the research study participants' right not to know these results. That being said, we still felt very motivated to try and return the results. And to answer some of these IRB questions, we first designed a study that was given to the next 225 participants that were recruited to the biobank. This study was led by a master's student, genetic counseling student at the time, Jamie Love Nichols, who is now a genetic counselor at Seattle Children's. We engaged a diverse team of genetic counselors, health behavior researchers, faculty from the School of Public Health, and people who were familiar with return of genetic results from primarily from cancer studies where they were sequencing tumors with clinical grade results and using that to guide in a precision health framework, the most effective therapy for those patients. So we had some preliminary data from a sort of slightly different but similar study. And so Jamie consented patients, gave the survey, analyzed the results, presented her work at a conference, and drafted the manuscript, which was published, took a while, but it was published in 2020 in the Journal of Genetic Counselling. So I've summarized Jamie's study in basically 2 slides. So of the first question, and we had a lot of information about teaching about genetic information and different scenarios, but the bottom line was, of the following types of variants, would you want to be informed? And for actionable aortic variants, 94% said they were somewhat likely, very likely, or extremely likely to want to know. And of those, 76% said they were very likely or extremely likely to want to know. I don't know if you can see my pointer, but that's the first row here. They were much less enthusiastic about non-actionable aortic or VUSs, but were also very interested in secondary variants related to other heart conditions or secondary variants related to cancer, and also highly motivated to learn about variants that would have implications for their family members. The second question, how would you like to find out that you have a genetic change? So again, this is a question from the IRB. We asked them if they would prefer to find out during an in-person appointment from a letter, from the patient portal, which was less positive at 82%, from a phone call, 75%, or by email, 63%. So with this information in mind, we developed a platform for returning results, primarily based around a letter as the initial contact from the research study. So just to summarize this section so far, and then I think Rajani will take over the next part. So we're halfway through. Basically, we recruited research study participants from an aortic clinic to join a biobank, and it's at about 5,000 individuals. We exome sequenced a subset of these patients who had aortic dissection and identified 26 with pathogenic variants using ACMG criteria. We surveyed participants and found that 94% of biobank participants would prefer to be informed about actionable clinical variants, especially those with implications for their family members. So next, we decided as a group in the CHIP steering committee that we needed to find a way to return non-CLIA results to research participants that was ethical, IRB approved, and also considered the minority of people who might not want to know. And at this time, we could not develop any CLIA results from the samples we had because the samples themselves were not CLIA. So the only way to get a CLIA result is to somehow go back to the patient. So Rajani, do you want to take over? I might just load the whole slide here for you.
Yeah, that'll be easier. Thank you, Cristen. So when I came into this, I wasn't there for the first part of the study, and I joined in little at this point, and we were trying to figure out, first of all, what do we do with these results? And we are sitting on them. We knew we had got them in people who are affected, but there's so many downstream relatives and family members that we can find through cascade testing who are potentially at risk. So for us from a clinical side, where this was something I did on a regular basis, I saw these families in a clinical setting. But now we have these test results that were found in a research setting. And how do we give them back in a way, as Cristen said, that's ethical and still giving them the right not to know? So for us, the intersection of almost translating this research into clinically usable information became not as much as should we do it, more about how can we do it correctly and in a way that is doing no harm, but doing as much good as we can. So some of the questions we had were obviously why you return them, because they are important to know, but how do we validate it in a clinically relevant setting without violating their privacy, without increasing healthcare costs, without worrying about discrimination in terms of genetic information and pre-existing conditions? And how are we going to do this in a way that we can prove that is not going to hurt them? So that's when we had, can I get the next slide, please, Cristen? That's when we had another genetic counseling student come in, Adeline Bell, who's on this, who's the primary author on this paper that we're discussing today. She has a dual degree, and at that point she was a genetic counseling student, but she has a dual degree in public health as well. So she had gone back into the literature and trying to look at, do people want to know and what are their attitudes towards getting results back? And what we found was that people do want to know. They want to know as long as it's not vague, as long as there's enough clarity for them to take care of themselves and their families. But they want to know as much as they can to be proactive about their own care and that of their relatives who could potentially be at risk as well. So this was the motivating factor as we were trying to think about returning these results. How do we return them in a way that is not going to hurt? So just the same way that Jamie did her pilot, we were trying to do this with Adeline, trying to figure out, can we return these results and then survey our patients to see not only how did they feel about it? What did they feel after they did it? Did they feel they got the information they needed? But also, what are the costs for this, for the research study, for a grant that's funding it, and potentially what it would mean if we were going to have to return research results and who's responsible for those costs. So this was the motivation for us to start doing this study. So what are the existing guidelines? When you have, I think most people in this area are clear that if we have something actionable, we want to give it back, but there's not very much data out there on how you do it correctly. And what is the kind of model? Do we do it in a letter? Do we do it first face-to-face? Whom do we use in terms of being able to give it as a clinician? Is it a genetic counselor? Is it a combination? Is it the primary care provider? So we were trying to analyze our model of doing it and see what we got out of it at the end of it when we did that after giving those results back. So we use these 26 initial cases to make that determination, knowing that the ones we were looking at are people who already had a clinical diagnosis, had an aortic dissection. So we were not really adding something to their medical history that was already not known in terms of a clinical phenotype. So that was critical for us because we didn't want to be opening anybody else to the issue of discrimination and pre-existing condition issues that came along with it. Can you give the next slide, please? So when we were looking at this, we had three main aims with this study when we started doing it. We wanted to know how our participants actually got, so when we talked to them about complex genetic information and what this means for them downstream, how much of this did they actually process and understand after they got it? So it's easy for us to say, oh, this autosomal dominant inheritance 50%, but how much of it did the implication really go down into their understanding? And were they satisfied with the way we were doing it and what they got out of it? Did they think it was worth it for them, for the time, the effort, and the emotional burden? And that is one of the things we worry about with genetics because it has effects on everybody. So if you find out something that potentially your children are at risk for, or your parents might have given you, or your deceased sibling had that you, so we have all these other issues that we were thinking about. So we wanted to make sure that we want to try and analyze what kind of impact does it have on them and their families? Are they understanding what they need to get out of it and reducing the misconceptions and misunderstandings? And also, what does it mean in terms of costs for the research team, for the healthcare system, and potentially at some point for our patients themselves if this becomes part of more routine care and research studies cannot keep picking them up. The research studies have their own budget limitations as well. We can't expect everybody to be paying for everybody's genetic testing. So those are our primary goals as we went into the study about 2 years ago now when we started it. Next slide, please. You want to take over this part, Cristen, and the research part?
Sure. So we ended up with the pipeline that we felt considered all these different aspects in terms of reducing risk, allowing the patient the right not to know, et cetera. And the pipeline looked like this. So we opted that the principal investigator, sorry for the typo there, summarized the pathogenic variant results to medical and genetic experts. And we received unanimous consensus to return results to participants. So that was the CHIP steering committee, as I mentioned. These are the physicians, the cardiac surgeons, the cardiologists who treat these patients in the clinic. Then once we decided we were going to return the results, we said, let's at least validate the genetic change itself in a new sample if we had one. So in some cases, we had stored the cell pellet when we spun down for plasma. And so we re-extracted DNA from the pellet, and then we verified that the specific genetic change indeed existed, at least in that specific sample, to help protect us against potential sample swaps or just a mistake in the exome sequencing. Our next step, which is when we reached out to the patient, was we sent, before we did that, we were concerned that when patients received a letter, they might call their doctor, call their cardiologist and say, I got this letter with it saying that there's a genetic result. What do I do with it? And we didn't want the physicians to be caught off guard. So at this point, we're still not providing any specific patient identifiers to the clinical team because we didn't feel comfortable unblinding the participant at this point. But what we did is we sent a letter to all of the physicians and said, and they're generally quite aware of our genetic study because we're recruiting from their clinic, but we wanted them to be informed that one of their patients was going to receive a letter that we have a genetic finding, but it's research level and they need to see the genetic counselor, just so that the physicians weren't caught off guard at a future clinic appointment. So next, we reached out to the participants. We mailed them a letter via US certified mail. We decided that the letter should come from Rajani, the genetic counselor, and myself as the study PI, even though I'm not clinical, just stating that we found something in your DNA, and Rajani can speak to this better than me. Actually, do you want to switch now?
So what we did with the letters, we wanted to make sure and this is a tightrope bounce, we were trying to make sure they got enough to know that we found something, but we didn't want to scare them, and neither did we want to violate their right not to know. So we went back and forth a lot on what are the verbiage we want to use, what is the wording we want to use for this. We finally came up with, you participated in this study, we found something we'd like to discuss with you further. If you would like to know more, give us a call at this number. So we kept it as general as possible without revealing what gene, what it was, but just that they were part of the study, and then we found something. We gave them a couple of weeks because we had the certified post. We knew when they received it. So we sent them out in batches of 5, trying to make sure that we weren't overwhelming ourselves as well. And we gave them 2 weeks from when they received it to wait for the phone call to come back. If we did not receive a call back, which for the most part we didn't, we received callbacks from very, very few people, then I followed up with a phone call saying, did you receive this letter? Do you remember receiving this letter from our study? We wanted to know if you had a chance to read it. I wanted to discuss it with you further, see if you had any questions, if you'd like to discuss this further in person. That, we kind of started with that. If they were okay with it, I still didn't reveal, I at that point did not know what gene, what mutation for each person we were looking at, because I myself didn't want to be biased, so I didn't have access to that part of the data at that point. I just knew that something had been found and this was the family that I needed to contact. Once they agreed to talking about it, and we made sure they were aware that all the costs associated with the genetic counseling, with the genetic testing would be covered by the study. And it had to be in person though. I mean, maybe today in the pandemic, we do things differently, but at that point it had to be in person. If they agreed to it, then they were scheduled for a regular clinical genetic counseling appointment with me. And that's the first time anything went into the electronic medical record. Till then, all of this was in a protected research database, all our call logs, all our discussions, nothing was put into the electronic medical record until the patient agreed to be scheduled for an appointment. Once they agreed to be scheduled for an appointment, it had to go through the clinical protocol because that's the only way I'm allowed to meet with them. So then they came in, we did a regular genetic counseling appointment that included a 3 or further generation pedigree, more importantly, to see if there are other people in the family that showed any clinical phenotype consistent with what we had found. I had access to the gene at that point. And then what this particularly meant for them, all of these again were people who had had aortic dissections. They were at some point told that this could be genetic. They were at some point told that their family members should undergo clinical screening based on AHA guidelines, the CT scan, the MRI, based on what they presented with clinically. But then these people came in, go into that data a little bit later. Some of them had already undergone confirmatory clinical testing. So the reason for this is they did participate in the biobank, but they had also been seen for clinical genetic counseling separately. And we already had some of them already tested that confirmed the findings we had. So we kind of already knew that. Here we were focusing more on people who had not undergone clinical genetic testing for different reasons. Either had not been offered, or they didn't have the resources to pay for it, or at the time of a dissection, somehow genetic testing is not top of your priority list. After taking into account all this, they came in for a genetic counseling visit. When they came in, they were asked if they'd be willing to the survey, which Adeline then administered for them after their visit with me. So they had their 1 hour. They would have Adeline, where she went over the survey and got their impression on what they thought about it, what they felt, what was their reaction to the letter, what was their reaction to the whole process, what did they understand, how did they feel, Were they satisfied? What improvements would they recommend? Things like that, which is all detailed in the paper. And we'll come into that a little more too. After they were tested, a blood sample was taken. We sent it off to a clinical lab that does regular, so it was a CLIA sample, a clinical sample sent off to a CLIA lab. And I followed normal clinical protocol for these families then, where they would get a call from me confirming the result, which was confirmed in all our cases. And then the normal cascade family screening. How do we reach out to the rest of the family? The way we process contacting family members, relatives, family letters, wherever they are in the country. So once they agreed to that, all of this became part of the electronic medical record. And then we went on to process it like a clinical test. Let me get the next slide, please. So just to summarize some of the things that came out, and this is more from a clinical angle because I am primarily a clinical person. We had, some of these are very, very large families. And these are the ones that jump out at me from here, that there's one of these, a couple of these families, I've met with up to 30 people in these families. So there's a lot of people that have been impacted by these tests, by these results. Some of them had been tested earlier, so we already worked them up. Some of them, the first time was through this study. And then downstream, and this even 2 years later, I'm still seeing children, siblings, their kids, all coming in through this primary first person that was confirmed through research. Have we saved lives? We'll come into that a little later. I have no doubt we have. I mean, that's the whole point of doing this, is you have someone who's at risk for an aortic dissection, and we're trying to identify them early enough to do something about it. And we'll come into that in another slide. Some of them had undergone confirmation through other research programs. Some of them had undergone confirmation through clinical dialogue. But in the end, we have a lot of them, even if they didn't go through the CLIA testing with us, we're still willing to be part of the study and the survey so that we could get some more of that information from them. A key thing for us also to know is, why did people say no? Okay, some of them obviously had been deceased and we didn't have any way in the IRB to contact the next of kin at this point, where we were with the IRB approval, which is something we need to think about for future. What happens if the person is deceased and we get information after them? It's still valuable for the rest of the family to know. Some people were lost to follow-up. We don't have updated contact information. We don't have an address. We don't have a phone number. Again, something we all deal with regularly in the medical field. Some people said, look, I know what I have. My family's all had a CT MRI. We know what we need to do. We just don't want any more being added to the anxiety we already have, which is something, again, we see not infrequently clinically. Some people like to go back to their primary doctor. They want to talk to their family because that's the person they trust more than this person they're hearing for the first time, which is, again, not unusual for us in the clinical. These are normal clinical scenarios. It has nothing to do with the research study. And I have others who say, I came there when the things were worst to worst. I never want to come back into that hospital again. It reminds me of everything that went wrong, which is, again, something we see not infrequently clinically. And then we had people who scheduled and just didn't show up, and then we couldn't reach them again. This was a minority, but again, it was important for us to know why people were saying no, so we could understand if there was something else we could do to make this easier for them if they wanted to know. Next slide, please. Just a quick snapshot of some of the people who were in this study. And I just want to be reading from my slides, but almost everyone we see does say they want to share this with their family. Sometimes people come and say, oh, you know what, they don't look like me, they're not going to have it, or that's a male, I'm a female, they don't get it. But once they've been through the counseling and they understand the implications, most people are out there saying, I would like to let all my family know. My family either knows, or they already have symptoms, or we're already doing what they need to do. An interesting thing, which we see again not infrequently, is it's my job to tell them. I will. What they do with it is up to them. To facilitate this, what I do is once they have a positive result, they get a blank letter that doesn't have their identifier on it, but it has the gene, it has the mutation, it has the laboratory it was tested at, it has a specific code so it can be linked back to their sample at the laboratory. It has my contact information if they wish to reach me. So they can just hand both email and hard copy. They can send it to their relatives saying, hey, this was found. Here's how you can get more. So I give a little description about the condition, about the inheritance, about the gene, about the risks of not knowing and knowing. I talk a little about the Genetic Information Non-Discrimination Act, which is a law in the United States for protection of privacy. All this goes into that letter. This is given to them, and they have the ability to share this without their identifiers on it. And that comes after CLIA testing. We send that to everyone. So that's one way we help facilitate their being able to share this information. Next slide, please. So what was our conclusion? And Kristen, please feel to jump in anytime with this. We were a little surprised that so few people reached out to us on their own. We did try to get to that with the survey. For some people, it was about, oh yeah, I opened the letter and put it on my kitchen table and I forgot, which again happens. For some people, it was, I remember giving blood for so many things, but I don't know what I gave it for. So I had no idea what this was about because we didn't put too many specifics in the letter. Again, we didn't want to violate the right not to know. One person said that she got it, but she was scared about what it meant. And after all she had been through, she didn't want to be scared anymore. Once we had the conversation, she felt a little better, but the letter itself scared her into, I'd rather not know. I'd rather put it away and not think about it. But for the most part, it was people who, oh yeah, I got it. I meant to call and I just forgot. Which is why the follow-up phone call for most of them was like, oh yeah, I'll call you. I mean, I'll come in. That was one of the things we were thinking about. How do we get to people when we consent them for the study itself? Do we now put in a plug saying, if we have something, we will send you a letter so that you know we have something and you'll have the right to call us. So if they expect it, are they more likely to call us back? What we did find was for those who came in, there was a very high degree of satisfaction with the whole process. They were happy with the letter. They were happy with getting the results. They were happy with the consultation. We had already, one of the things we found was scheduling. The way we schedule this is we already blocked time on my schedule that as soon as they called, we'd have a spot available so that they didn't have a long wait from the call to the visit. That may not be something that's always feasible if you have a larger program with a large number of results coming in. These were 26. We staggered them 5 every 2 weeks. So we had that flexibility to do that. But most people were fine with coming in, understanding, getting the testing done, being part of the survey. And most people were actually quite happy that they had done it and got the results back. And more importantly for us is the regret for having done it. And the anxiety and angst of having gone through this was much lower than we had even thought it was going to be. So for us, that was reassuring that the downstream negative effect of this was not something that would prevent us from doing this. Because we wanted to analyze and see how many people would potentially have issues if we did do this. And those who didn't want to talk, didn't talk. So we'd already kind of self-selected for people who wanted to know, because those who didn't want to know had told us up front they didn't want to know. So this kind of helped us.
If I'm reading the numbers correctly, I think 16 participants received the letter that had not previously had genetic testing. And of those, 11 came in to meet with you. And of those 11, I think 10 had confirmatory genetic testing.
Yep. And all 10 of them confirmed what we found in the lab. So they were all consistent.
That was very reassuring for me.
Yes, every one of them was consistent, which we didn't expect it to not be any other way, but we needed to make sure. And just another thing is, when I talked to them about their mutation, when they came into the visit, the first time they heard about the gene that was involved was when they came in for the clinical visit. So nothing was mentioned about whether it's FBN1 or PRKG1. None of that was mentioned until they actually came in for a clinic visit. And when I made that phone call, or they called me to schedule that appointment, they were made aware that this was now moving forward going to be part of their electronic medical record. So we made sure that they were aware of that. And then the actual variant and the gene was only mentioned at the visit, letting them know that this was the research finding. The reason we were doing this is to confirm it, and no action was to be taken until we had the clinical finding confirmed, the research finding confirmed, which we usually got results back in 2 weeks. So it was not a very long wait from we actually got the blood and then sent them. They called a follow-up call back about it.
Yeah, when we considered depositing this information into the EHR, we felt quite strongly that the patient should be able to control if and when this information entered their EHR, because although GINA protects them against several types of insurance, it doesn't protect against certain others. I think it's long-term disability
and life insurance,
and
life disability and long-term care.
In this case, it might be less relevant because these are patients who've already had a dissection. So presumably the genetic information doesn't change. They're already reasonably high risk at obtaining insurance, but that is a consideration more so for considering secondary findings where it could impact, unfortunately, in the United States, their ability to get life and long-term disability insurance.
And when we talk about family members, it's something also that I bring up with them, that this could have an impact on an unaffected relative to be able to get life insurance. While health insurance and employability is protected by the law, except under certain circumstances, because the others are not, this is something they're more aware of, saying, if we confirm this finding and you have unaffected relatives who want to be tested, they need to meet with someone in genetics so they're fully aware of all these implications and have the time and ability to make whatever arrangements they want to make or need to make before they consider genetic testing. So as Cristen said, as we go into secondary findings, this might be more relevant for us than people who already had a dissection. Do you want to go into this, Cristen? The favorite part?
Yeah. So as I said, the IRB was very clear that this should not cost the participants any money, even for clinical validation of the research genetic result. I'm hoping with time that might be something we can argue against. For example, if you're in a study involving an MRI and they say, we found something, you should get it checked out by your doctor, you would presumably go to your doctor and get a new MRI through your insurance, as opposed to having the research study pay for it. But genetics seems to often have its own special caveats in terms of ethics and IRB. So the IRB was pretty firm for at least this pilot study, this round, that they wanted the research study to pay for the CLIA validation of their result. So our in-house confirmatory testing before we sent the letter to the participants cost us $166 per participant. And that was, personnel time and sample handling, and as well as we did some targeted sequencing to validate the finding. Personnel to return results in terms of project manager and genetic counselor actually wasn't the biggest expense. We should probably be paying you more, Rajani, but reimbursing your time and the project manager to make phone calls after the letter was received, and your time with the pre-test counseling that the research study paid for was $50 per participant. The CLIA validation for the 10 participants who chose that route was $250 per person. And then extra costs of, I think we pay for the room in which you see the patient, costs of the certified mail, and phlebotomy charge for getting a new CLIA blood sample was $52 per patient. And so the total per participant who gets CLIA testing is approximately $518. I think we report in the study, if you average over the 26 patients who had a pathogenic variant, it worked out to $400 per patient.
Yeah.
On average, but that would kind of depend on how many people came in for genetic counseling and the CLIA validation, et cetera. So it's somewhere in that neighborhood. It was something like $260 just to do the validation, send the letter, et cetera, follow-up phone calls, up as high as $500 or $600 for the patients who ended up getting CLIA validated testing. So it's not super cheap, but on the other hand, this is a biobank of 5,000 people. We did exome sequencing on 550 for a series of patients where 10% of them had a pathogenic, essentially Mendelian variant. So that was a pretty high proportion of people who had something that was worth returning. But I do think it's worthwhile to consider the costs in advance of setting up a biobank, because you do not want to be in a position of having a result that could have saved someone's life if you returned it. A few people had deceased between entering the biobank and when we got around, managed to implement all of this to send them a letter. And honestly, that feels pretty terrible. So I think as you're collecting patients, if you have the possibility to save their lives, it just seems like, of course, we should try, keeping in mind all these ethical considerations.
And I think that's kind of where we go when we go to the next slide is they have this risk for sudden death given these conditions. We know there's risk for family members. We know that it's hard to find, especially aortic disease that's so asymptomatic until they come in with that dissection or their incidental findings. So I don't think there's no way we can put a cost to a life that was saved. But I look at also the downstream revenue, the downstream cost for this. Now, if we have someone who has no genetic testing or genetics nothing found, we're looking at CTs and MRIs on all first-degree relatives. Now, in the United States, with our managed care system being the way it is, these things work out really expensive. Your CTs can be upwards of $2,500, MRIs are even more. Then there's the risk of radiation and the contrast and everything else we're doing for that. And then you're thinking of repeating it every 5 to 10 years. There's so much downstream costs and other issues that come with this versus the genetic testing. It's a one-time, if we find something and relatives get a yes or no, that's done for them. If they're yes, they continue with the screening. If they're no, then they never need to be seen. Their kids don't need to be seen. The costs are huge in terms of savings as well as, time and management. One of the things that has been continuously evolving in this country is how genetic testing is paid for, who pays for it, which insurance companies pay for it, and how much it costs. In the 5 years that I've been doing aortic disease, I've seen a dramatic drop in actual genetic testing costs. So I think as we go into an area that more and more companies are coming into this and they're making it easier and easier to be tested, hopefully the costs associated with the testing will also drop. Right now, just for example, the lab that we used for this, it's $250 to do that single site testing. But once they have a confirmed finding, then all their first degree relatives can be tested for free. So it makes a big difference that if you have one person tested and then everybody else can get in and be tested if they wanted without having to deal with the CTs and MRIs and scans and doctor visits and everything else. So I think that's going to evolve. It's an evolving story. We see $500 per participant at this point as these kinds of programs increase, and hopefully we see more research results being identified. If the studies are able to pick up or not pick up, even if they're able to be given in a clinical arena, can we actually find the cost dropping to a point that it becomes more affordable for a larger number of people, and the research studies don't necessarily have to bear the cost of the testing. They might have to bear the cost of the initial contact and mailing and getting things done until we start the electronic clinical medical record entry. Once we get to the clinical arena, can we now switch to the clinical management in a way that becomes more affordable, both for our healthcare system and for research and for the patients and families themselves? It's something that's constantly evolving, and we do keep thinking about a lot. So I'm hoping that as we do more secondary findings, we'll be able to offer this to more and more people.
So just to wrap up and leave a few minutes for questions. It is possible. We developed a pipeline to return research level genetic results that are not CLIA that will impact clinical care. And it was IRB approved, and we hope delivered in a responsible manner. When the patient controlled whether their genetic info entered the medical record, their stress level was low in at least the population that we studied. And this, our sample size was not huge. It is what it is. And we also mentioned the possibility of return of results in the consent form, even starting in 2012. It wasn't completely out of the blue. In my opinion, we study genetics to help people. So let's help people when we have the chance. And the IRB worked with us and took into account the survey information that we developed to help us develop a protocol to return research level results with the patient's preferences in mind. And however, it was substantial time and expense to the research investigators to validate and return results. And you can tell how much time and thought and care Rajani spent actually returning these results. So obviously it couldn't have happened without her dedication to making this a reality. So we recommend the cost to be built into the cost of biobank recruitment because, like I said, a PI of a study does not want to be in a position of having potentially life-saving information that you have no way to actually get back to the patient. So just a quick thanks before we take questions. So Brooke Wolford did the analysis on the genetic exome data. Oh, Jamie's picture vanished. There it is.
No, it came back.
Okay, Jamie performed the first survey to find out how and whether patients wanted their results back. And then Atte performed the post-genetic counseling visit survey for patients who actually got their research genetic results back. Jen McNamara played a huge role as project manager for CHIP. Whitney Horsby played a big role in helping these papers get to the publication stage. Scott Roberts was fantastic as the health behavior, health education survey expert, as well as genetic counselors Wendy Ullman and Patty R. Scott helped us develop all the pipelines. So thank you to the team, and we're happy to take questions in the time we have left.
Looks like we have a lot of questions in the Q&A and the chat.
Sorry, Nikki, we went longer than we thought we would, but
that's quite all right. That was really fantastic. Thank you very much, both of you. I'm just going to start off with a question about the kind of the survey about whether participants want their results or not. And it's quite intriguing to me that 94% say they wanted results, but only 88% wanted them through in-person meetings. When I suppose in the genetic counselling field, or at least in my opinion, when I looked at this a while ago, in-person meetings are kind of seen as the gold standard. So is this kind of suggesting that some people really don't want to see, they'd rather have this result kind of in their own homes via a letter, and then make the decision as to whether they want to see somebody?
If you had asked me this question pre-COVID, I would have had a different answer because we never did counseling, at least in our facility, without seeing them in person, and now we do. I would not personally be comfortable giving out genetic information without meeting with them. It doesn't have to be in person now. We can do it by video, which is ideally better than telephone. But I just look at it saying, every time you talk to them and the kinds of questions you get back, you don't really think about them until you actually meet with them. A simple thing that we take for granted, but most people don't understand that they don't skip generations. Just because you don't have a symptom, it's not that you're not going to get it. Or what does this mean for my child, or the sex differences, or it makes a difference. I think meeting with someone in genetics has a big impact, whether that has to be in person. Now we've changed how we do medicine and healthcare a lot with the pandemic. But I think meeting with someone in the field is probably essential rather than just sending them a letter and saying, hey, interpret this. You've got FBN1 C.726 C to T and good luck. I mean, that's a lot, I think, to throw at someone.
Yeah, and also you can't gauge their understanding and how much they understand the letter. So yeah, no, I definitely.
And genetics is a crystal ball. It's scary. You don't always want to be looking into it.
Yeah. On kind of a practical question on the study. So I know, so you said that you took known cases of aortic dissection and then age-matched controls. So did you actually look, so I imagine that they might be a slightly older population. Did you look in the kind of remaining individuals that might be slightly younger as to whether there might be any secondary findings, so any pathogenic variants in kind of younger biobank participants?
we did look for secondary findings, not through the same lab in Texas. All of the sequence results to Massachusetts General Hospital to, again, sort of outsource the calling of pathogenic variants. And we do have about 3 times the number of pathogenic secondary findings as we did related to dissection. And so we're working on developing a pipeline to return that. It's just slightly different because, again, the person doesn't have the condition, so it's even more out of the blue. And we also have to basically paraphrasing Rajani, but we basically have to provide for her a physician who's an expert in that specific disease that's been predicted by genetics for each of their appointments. In the US, genetic counselors see the patient in some sort of partnership with a specific physician. So we did look, we haven't returned them yet because it's slightly more complicated and slightly less urgent than the dissection variants we felt, but we are working on that next.
It's a very interesting difference between the setup in the UK and the US. So in the US, you are much better set up with, as you say, genetic counsellors twinned to the primary care physicians. In the UK, we only have genetic counsellors in very specific fields, and most patients don't have access to genetic counselling that easily, and a lot of the burden falls to the consultants, which is, yeah, and I think it's very valuable for us to kind of expand our genetic counselling setup in the UK, especially as we have more and more of these genetic studies. We have a couple of questions on specific genes. So one from Andrew Wilkie is, you mentioned the list of genes that you interrogated, but I didn't see the actual list. Did you include SMAD6? And what is your view on SMAD6 testing in this clinical context?
Rajani, do you want to comment on
We didn't have
SMAD6?
SMAD6 in this list to begin with, I believe. And you can correct me if I'm wrong. SMAD6 we're clinically just starting to offer now, but it wasn't part of this initial list, if I remember correctly.
Great. And then kind of Brian Zhang has asked, can you give examples of how the counselling information provided was different depending on the gene that was found?
To some degree, it depends on the clinical phenotype. So for example, if I am counseling for an FBN1 versus a collagen 3A1 versus, there is a difference whether I'm looking for vascular EDS. The counseling, they're all autosomal dominant inheritance, so that's not the issue. The issue is more what I'm trying to get out of the family history. So if I am suspicious of a collagen 3A1, I'm trying to get more details in terms of arterial bed disease and organ rupture, thinking about vascular EDS. If it's a PRKG1, since these are the ones that are on the list, they rupture at minimal dilatation. So then I'm looking more at people who may have had a clinical study, but still suddenly collapsed without having any impact. So the counseling to some degree does make a difference. A TGFBR1 or 2, again, we're looking at age related, how it makes a difference versus an FBN1, what I'm looking for. So the counseling, I would say, depends more on the family history than really on the gene itself. Later on follow-up, once they're confirmed, you tend to be more aggressive in monitoring with some of the genes that have impact at lower ages and lower diameters. So I don't know if that answers the question, but it varies. And that is no different whether it was part of the research study or whether it's clinical management. It's going to be the same depending on what gene we're looking at, because our cutoffs vary and family screening varies, and what kind of follow-up screening we do varies based on the gene.
Yeah. So another question that started off by saying wonderful talk by both of you. Do you plan on following up with patients to determine if, after knowing their genomic changes, how many altered their lifestyle, pharmacological interventions, etc.?
The ones we saw in this first pilot were all people who had dissections, so they're already being followed for that and coming in for regular screening. The few family members that I have seen or continue to see after that, there are definitely interventions that are done based on their clinical presentation. Have we thought about doing studies in that angle? Not yet, but just before this talk, Cristen and I were talking about what is the next step on how we involve the next batch of our students trying to analyze down the next step in the study. So hopefully that is something that we will be thinking of looking at, that when we had unaffected relatives then being found to be carriers or carrying this gene, what kind of interventions have they been pursuing or what have they done based on this finding that we did? So it's a good point and appreciate you bringing that up.
Yeah, and we have a genetic counseling training program within the Department of Human Genetics here. So we have access to, I think there's about 12 students per year, and they are absolutely top notch. So it's a good pairing.
Yeah, in contrast, in the UK, I think there's only 2 programs that train genetic counsellors, and only every other year. So there's not very many of them actually being trained up even in the UK. interested in a question kind of more broadly than this study. So you said that it was kind of a very high rate of people wanted to inform their family members about their results. And I wondered if this might vary. So in a lot of these cases, you said they had existing family members that had the similar conditions. Does somebody's willingness to return a result to their family members kind of depend on this? So I'm kind of thinking that if somebody's the only person in their family to have a condition and they know a genetic result, they might feel a bit guilty and kind of want to, and maybe have more of an inclination to hide that than if if the family are more aware of the condition and actually it's kind of something you could communicate more broadly.
Guilt, yeah, I mean, guilt comes in all flavors and shapes and sizes, right? And I don't think this is unique again to a research setting. This is something we see very regularly in the genetic counseling arena. In my experience, and this is anecdotal, obviously, when you have family that has multiple family members, it feels very different than obviously you're the first person off. Do they hide it? Again, I really think that depends on the person. I have some people who have found this and said, I've gone through this and I never ever want anyone in my family to experience this as well. And they're very proactive about sharing things and getting people in. And there are times that I've met with 10, 12, 14 people from the same family at one time, like in a conference room, because they take the initiative to bring everybody in because they want to make sure this doesn't happen to anybody else. Versus there are other people who want to, like there was one person who said, you know what, I know what this happened. Everyone in my family is healthy. It's not going to happen to anybody else. I don't want to know. So I think that's more personality than whether you're one person or 10 people in the family. That's been my experience at least.
Okay, great. So the question is, do you think the possibility of somebody getting bad news might actually affect people's decisions to actually participate in genetic studies?
Absolutely. All the time. There are people who come and say that I don't want to ever see you again because you remind me of everything that's wrong. There are some people who blame you because they're the bearer of bad news. That's something that as genetic counseling trainees, we are constantly reminding our students that don't internalize it because you are considered the one giving bad news. But at the end of the day, I think after they've had time to process what's just come and hit them from left field and suddenly feeling responsible, the worst case scenario I've seen is when you have a child who something serious happens to or we can't save them, and then you realize it's come from a grandparent who doesn't want to have who suddenly feels very responsible. So yes, it does make it hard, but I think that's where the counseling part of genetic counseling comes in, that you're there to give it to them bit by bit, follow up with them, check in with them. And this is the clinical arena. So if I feel someone really needs help, then I will follow up in a few days when they've had time to process. I'll get them to a social worker. So we kind of do what we need to do, giving them time to cope. And this is true of any aspect of healthcare, right? I mean, I think about genetics, that's what I do, but I don't think that's different in cancer or anything else.
I think kind of, I work a little bit in the kind of developmental disorders space, and I think there's also a flip side to that, that often it's really, really reassuring to patients and to parents actually to say that it's not their fault, it's something genetic. So I think, yeah, there is also a flip side to that sometimes. And
that's why being in person makes them so important, because you can intellectualize it all you want, saying this is not my fault, but when it's your child or your grandchild or a loved sibling that you suddenly feel responsible for, it gets very difficult. And being able to have that personal contact and whom to talk to makes a difference.
Yeah.
There's also there's a question on polygenic risk scores.
Yeah, there we go. So we've got one left, so let's add that. And basically, so dissection has association with germline conditions like connective tissue disease and Ehlers-Danlos, but are there enough established common variants to generate something like a polygenic risk score?
I think Kristen's answering that as we speak.
Oh, Kristen, you're muted. We can't hear you.
Apologies. In my opinion, polygenic risk, this is my personal opinion, polygenic risk scores are not ready for prime time. This was a very specific situation of basically autosomal dominant variants, annotated as pathogenic. I felt more comfortable that we were blinded to case and control status. Rolling out something that has public health potential benefits, implications for increased or decreased screening, medication changes, preventive efforts. That's really, to me, a whole separate kettle of fish. with so many different ethical considerations, how it's rolled out at scale, who delivers the information. You know, to me, it's not worthwhile giving people genetic information if there's nothing they can do for it. That's my personal feeling.
Totally.
So to me, it's completely different, a whole much higher level of uncertainty in delivering a result like that. That's really, to me, probably only useful in sort of public health situations where you can impact levels of screening or preventive therapies. Rajani, do you have any opinion on polygenic
No,
scores?
I mean, I totally agree. Polygenic risk scores are, I don't want to go there. I'm not ready.
Not ready for prime time.
No, they're not ready. I'm not ready. Because I mean, how do we know what to, you know, what do we do with it, right? Do we have a set, what am I going to do with the 20% versus 32% versus the 63.5%? Until we have more firm data and we can actually act on it. I'm very, for all that I love genetics, I'm also very careful about not doing things that don't need to be done.
Yeah,
because then you do more harm than good.
definitely. Perfect. Well, I'm going to come in with my thanks again. Thank you very much, both of you, for spending your time on this. It was a really fantastic event. And we've recorded it, so we'll be uploading it online for people to watch in the future as well. Right.
Thank you for
Thank
having
you
us.
both.
Thank
That's
you,
quite
Nicky.
all right.